Now, what about the large group of patients who have non-neoplastic cysts? And certainly we'll talk about neoplasms. What we want to talk about with non-neoplastic cysts are these three: postmenopausal, polycystic ovaries, and go into more detail with respect to hemorrhagic processes that could include endometriomas and hemorrhagic cysts. So let's start with postmenopausal women who have cysts in their ovary. The first thing I would like to do is put color on and make sure, there we are, dealing with a cyst in the ovary. The other fluid collection was just a vessel. Point one is that postmenopausal ovaries, whether you're on hormones or not, should not be terribly vascular. So note whether they are or not, and hopefully they won't be. Now, many articles have been published about postmenopausal cysts, and the first one was, again, Debbie Levine. She was either a medical school student or a radiology resident at this point in time, who noted a large number of postmenopausal cysts and commented that cancer did not develop in any case. And this has been subsequently shown in other literature that has been published. And these cysts have been measured as 5 centimeters or less in diameter. The article that Dr. Levine wrote noted a 17% incidence, subsequent articles a lower incidence, possibly because of the size of these cysts. If you measure every teeny little fluid collection, you will have a higher incidence. But most of these, or I'd say about half of these, are going to resolve within the next year or two, should you follow up these cysts. The consensus statement suggests, because they're so common to see small cysts in postmenopausal women, that if they are a centimeter or less, probably should not follow them up and consider even not reporting them. As again, you start mentioning the word cyst, these people will come back to you. And since these are benign, non-threatening condition, don't need to follow them up. Between 1 and all the way up to 7 centimeters, the consensus statement said definitely to report this and then consider doing a yearly follow-up. Many of these cysts are going to stay stable in size or grow very, very slowly, which is why the thoughts were that they don't need to be reported. But once you get to be maybe 7 centimeters, because of the threat of possible torsion at that point, you might want to consider removing these cysts. And 7 centimeters and above, again, the idea would be to either remove them. I'm not sure how MRI would add to the ultrasound in terms of saying what this is, but most of us, I think, were in the mindset to consider doing surgery at that point. Well, what about number 4 on our list of common treatable, common benign conditions that are seen in the ovary? If you see a large number of small peripheral, these would be the location of follicles, as we see in the picture here, people have described these as looking like a string of pearls around a woman's neck. This is consistent with a polycystic ovary. Now, a consensus statement came out a few years ago with these numbers: more than 12 peripheral follicles, none of which is greater than 10 millimeters, and the ovary is slightly enlarged, usually round. I find all these numbers a bit confusing to remember, so I would like to suggest an easy way to remember a polycystic ovary is using that rule of 10. If you have 10 follicles, you're probably going to have 12 and more, because there are many at the periphery, none of which have a diameter of greater than 10 millimeters, and the ovary is somewhat enlarged, having a volume of greater than 10 cubic centimeters. To diagnose a polycystic ovary, the consensus statement said it only needed to affect a single ovary. Now, in my report, I don't report these as polycystic ovarian syndrome. That is a clinical entity with amenorrhea, hirsutism, and often obesity, and abnormal endocrine function, increased androgen and LH. So my job is to define what the ovary looks like, and I would call this a polycystic ovary, and let the clinician figure out if this is part of the spectrum of polycystic ovarian syndrome. These ovaries are often scanned by us because patients are manipulated because they're anovulatory in an effort to get pregnant. And these ovaries are very sensitive to hormonal manipulation. These are the people who not uncommonly develop ovarian hyperstimulation, which we've shown you an example of with the thecal lutein cyst. Interestingly, even though these women are amenorrheic, they have a very vascular stroma, particularly in the center of the ovary, with a low resistance pattern. And I find this rather intriguing because when women are typically anovulatory, and the most common reason for that would be a case like this, multiple small follicles throughout the ovary, in an avascular ovary, the most common appearance or reason women will have an ovary like this is a woman on oral contraception. And I don't know why these women are so vascular in their ovaries, but when I see what looks like a polycystic ovary, I always turn on my flow and see if it's a hypervascular ovary. And more than likely, if it is, it will be a polycystic ovary. Now, moving into another entity, which is very common and classic, is the woman who has a homogeneously echogenic mass in the ovary. Sometimes hard to see if the echogenicity of it is similar to the background of the ovary, and you can see some small follicles here peripherally. Turning on this case, you can see actually there's a fluid debris level. Not always going to have that, but not uncommonly with a dependent debris level. Notice the fluid debris looks vertically, and that is not because the woman is in an unusual position. It's just because whenever we look at a vaginal scan, as we see in this case, the front of the probe is always put on the top of the screen. So this actually is the patient's feet, her head, anterior and posterior. So it's an anterior-posterior fluid debris level. If you were to put color on in this entity, which is a classic for endometrioma, you can see a little bit of movement with the Doppler, with the color on. But when we put Doppler on, notice how we've increased the flow greatly in that endometrioma. And this is to remind me to tell you, of course, that Doppler has increased energy, and that's why we're striking these echoes more forcibly, causing them to have this kind of motion. And I urge you, when you see such a thing, to be reminded, if you're doing pregnancy-related scanning, particularly in the first trimester, I am definitely not a fan of using Doppler at that point because of delivering higher energy to a developing embryo. So I would urge you to not use Doppler unless you have a very good reason to do so. And honestly, for many years, I have not found that good reason in my early pregnancy studies. But let's get back to endometriomas. Most women who have endometriosis know their diagnosis. And what is the most common ultrasound appearance in a woman who comes in saying, I know I have endometriosis? Most commonly, it's a normal ultrasound study because they will not have a focal endometrioma. So don't be surprised to see a normal study. When a woman develops an endometrioma, it typically occurs within the ovary, and we've just shown you what they look like. They're masses that are filled with low-level homogeneous echoes. What did the consensus statement say about endometriomas? It was said that initially we should do a follow-up in about anywhere between 6 and 12 weeks. And why would that be? Because we want to make sure that really is an endometrioma, in which case it will not change appreciably or it won't go away. And there is, as we said, a crossover between endometriomas and hemorrhagic cysts, which should go away, hence the short-term follow-up. But then the consensus people also suggested we do a yearly follow-up just to keep our eye on these things. They should not go away, and they may grow a little bit slowly. But if there's an appreciable change in the size, probably should be removed because there is, unfortunately, an association in women with chronic endometriomas to subsequently change the appearance and become malignant in the way of developing an endometrioid carcinoma. So that's why we want to keep our eye on women with endometriomas. Now, most endometriomas look the same, but occasionally we have one of them that looks different from the rest of the gang. So here's an example of a slightly atypical endometrioma, much coarser echoes. And here's one that frankly looks very, very atypical with mural nodules, thickening of the wall, septations, and even flow in the septations. when I see something like this, even if a woman has a history of endometriosis, I'm going to be concerned. In this case, to the point that if I get concerned, then the clinician will get concerned along with the patient, and it will be removed surgically. And this was proven to be an endometrioma. So I'm showing you a spectrum. Fortunately, this is an unusual situation. Here we have a typical endometrioma in this woman, and subsequently follow-up showed it looks very different. It looks more like a hemorrhagic cyst that's evolving. But in this case, this went back and forth over time, subsequently being surgically proven to just be an endometrioma. And what I think happens here is these women cyclically will bleed into the endometrioma, and the blood products may evolve as a hemorrhagic cyst, but only to hang around for the long term, become low-level homogeneous echoes, as we see here. Occasionally, you may see something like this in the wall of the bladder. Now, I'm not saying this is not, you can't tell this from a bladder neoplasm, but a woman who has a history of endometriosis, and particularly if she has cyclic hematuria, you might want to think about the possibility that this is an endometrial implant in the wall of the bladder, as we see here through a cystoscope. This is an interesting lady who does have endometriosis, and I'll show you her endometrioma in a minute, but complained about pain near her umbilicus. And of course, if somebody's complaining about pain, it's my job, I believe, to go see if I can help find out what's going on. So we saw this mass near her umbilicus, and we saw it again a while later that it was even getting bigger, now sort of bilobed, and she had endometriosis and endometriomas in her uterus, in her pelvis, in her ovaries, and we can see a homogeneous, very typical appearing endometriomas. So what is causing this mass up by her umbilicus? When we looked at this patient with a real-time clip, you can see this is in the abdominal wall, right next to her umbilicus. So what this represents is an endometrial implant in the scar, thanks to a laparoscopy that was done. And I've seen certainly endometriomas in this location. I've seen them in C-section and other scars. And endometriosis can have a way of implanting far away from the ovary and often will be cyclically painful as there's hemorrhage into these unusually located endometriomas. Now, if you look at this next case, there's a very hyperechogenic area occupying the majority of the ovary that is avascular. It doesn't have the typical appearance of the low-level homogeneous echoes of the endometrioma, but it's avascular. And this woman, in all likelihood, is acutely symptomatic at this point because she has hemorrhaged into a cyst, i.e. into a corpus luteum. And these can be very, very painful. And this is what the acute hemorrhage should look like. These are going to go away with time, a period of months, and we shouldn't worry about them. So I mentioned ovarian cancer does a lot of things, but it rarely hemorrhages. So if you see what looks like something that could be hemorrhage, if you elect to follow it, and not everybody does today, according to our consensus statement, it should resolve. But if you were to follow it, these hemorrhagic cysts evolve often in a predictable manner. One way they evolve is to develop a retraction of clot, as we see in these two examples. Now, you might say to yourself, why is this not a mural nodule with a tumor? Well, for one thing, it is avascular, and tumors are typically vascularized. So, can we do anything else? Another case, avascular, probably a hemorrhagic cyst with a clot in evolution. Now, I know that if I have a clot, it is going to be relatively soft. And what I like to do at this point is take the transducer and push against it to see if it's soft, if I can get it to jiggle. And this is one of my favorite clips where I show this clot moves and jiggles, and tumor doesn't behave like this. If I have a tumor and you look at a clip, you can see this is much firmer, doesn't move, and of course this woman also has ascites. If I was to show you what color looks like in a minute, this is a mural nodule because it is firm, and but if I showed you what it looked like with color, it is going to be vascularized in contrast to a cystic structure with a hemorrhage in it that is evolving. So mural nodules should be separable from hemorrhagic ovarian cysts in evolution. But don't get fooled. Keep your eyes open, and if there's any question, of course, get that short-term follow-up.